an old ununited fracture of the tibia and fibula with severe angulation of the very thin bones. What is the likely cause? Poliomyelitis with paralysis of both lower limbs. Question 159. What abnormality can be seen? Posterior dislocation of the elbow. Discuss the mechanism of injury. A fall onto the hand driving the forearm backwards. Outline the plan of management. Anesthesia with an adequate muscle relaxant must be administered. The olecranon is pushed anteriorly while the forearm is slowly flexed from the extended position. Post-reduction X-ray is always necessary as associated fractures of the coronoid process of the ulna and head of the radius are common. Postoperatively, the patient should be splinted in an above-elbow padded back slab, or alternatively, a collar and cuff sling for about 3 weeks. Question 160. What name is given to this particular fracture? A Barton's fracture. The X-ray demonstrates a fracture line which runs into the wrist joint. The distal fragment is displaced anteriorly. Outline how you would treat this patient. This fracture should be reduced in the same way as a Smith's fracture. A special T-plate or Kirschner wire may be required. List the important complications. Post-reduction, the fracture is easily redisplaced and inherently unstable. Other complications include stiffness of the fingers and wrist, malunion and instability, osteoarthritis of the wrist joint, rupture of the extensor pollicis longus tendon, Sudex atrophy with osteoporosis of the wrist due to autonomic involvement, median and occasionally ulnar nerve compression. Question 161. What deformity does this X-ray show? The X-ray shows malunion or an old hypertrophic non-union of a fractured shaft of humerus. Other X-rays and a tomogram, nuclear bone scan, or a CT scan may be necessary if clinical examination is equivocal. Discuss a method for correcting this problem. The deformity can be corrected by excising the sclerotic bone ends or stabilizing the fracture with a locking nail or plate, plus bone graft. This is a difficult operation as a radial nerve is often adherent to the fracture. In this patient, the mobile, painless pseudarthrosis was left untreated. List several causes of delayed union following a fracture. Delayed union may be caused by infection, markedly displaced bone ends with interposed muscle, excessive movement at the fracture site, inadequate blood supply, pathological bone including secondary deposits, and Paget's disease. Question 162. A 40-year-old African man attended hospital for the first time with a history of trauma to his back. What is the cause of his injury? Bullet wound to his spine. What are the likely complications? Paraplegia with sensory, motor, and autonomic involvement with bed sores, contractures, and bladder paralysis. He may also have penetration into his abdomen with injury to spleen, liver, kidneys, intestines, and other abdominal organs. Question 163. What is the diagnosis? A dislocated patella. Outline your management. Close reduction. Immobilize with a splint for 6 weeks. List the underlying condition predisposing to this condition. Patella alta, a high riding patella. Undeveloped lateral femoral condyle. Genuvalgum, particularly in overweight adolescent girls. Question 164. This man was involved in a brawl at a pub. Name the structure that has been fractured here. The zygoma has probably been fractured. What is the common cause of this fracture? A direct injury, as this bone forms the prominence of the cheek. What late complication may occur? Depressed fractures, if not treated promptly, may lead to a flat cheek which will prove difficult to reconstruct later. Infraorbital anesthesia is a common disturbing symptom which may take many years to recover. Question 165. What is the cause of this deformity? Varus deformity of the lower left tibia due to malunion. There's gross shortening of the lower leg. There's a surgical scar over the anterior surface of the tibia. The leg has been shaved prior to surgery. This fracture is a result of a motorcycle accident. Is any treatment required? Operative correction with osteotomy and internal fixation with an electrical bone stimulator or bone graft, or both. Post-operative physiotherapy for stiff ankle and a raised shoe for shortening of the leg. What problem is likely to occur at the knee and ankle in the future if this deformity is not corrected? The altered biomechanics of the knee and ankle joint due to the angulation may lead to osteoarthritis of these joints. Question 166. What is the diagnosis? Supracondylar fracture of the humerus. List the main complications of this injury. Brachial artery injury with occlusion or division. Flexor compartment syndrome with Voltmann's ischemic contracture of the flexor forearm muscles. Radial or anterior interosseous and median and ulnar nerve lesions. Elbow stiffness, mainly due to loss of extension. Malunion or epiphyseal damage with cubitus varus or valgus. What age group is commonly affected? Supracondylar fractures are very common in children. Question 167. What abnormality can be seen? Acromioclavicular complete dislocation. What is the likely cause? Fall on to the point of the shoulder. What is the usual treatment? Triangular sling for 3 weeks and early mobilization. The dislocation is not reduced. Occasionally, internal fixation is required, usually in young women and mainly for cosmesis. Question 168. A 30-year-old man who sustained a fractured shaft of the humerus 3 months earlier now has this picture. What structure has been injured? The radial nerve, causing a wrist drop. Where on the upper limb may the trauma have occurred? Lesions at several common sites produce this picture. High lesions due to trauma or pressure to the axilla, such as with crutches. The triceps muscle is also compromised. Humeral lesions due to fractures of the mid-shaft of the humerus. Low lesions due to fracture dislocations at the elbow. Describe the sensory loss to this hand. The sensory loss is over the dorsal aspect of the hand at the base of the first and second fingers extending to the wrist. Question 169. An 8-year-old boy presents after a fall off his bicycle. What abnormality can be seen in this X-ray? There is an incomplete green stick fracture of the base of the neck of the femur. In a child, part of the periosteum in this type of fracture remains in continuity. Do not confuse this with the normal epiphysis seen in this X-ray. Give 2 alternative methods of treatment in this case. Bed rest and skin traction. Alternatively, hip spica, crutches, and early mobility. Question 170. What is the complication seen in this X-ray? The X-ray shows avascular necrosis of the proximal pole of the scaphoid following a fracture of the waist of the scaphoid. What other complication is likely in the future? Severe osteoarthritis with a destroyed wrist joint. Question 171. What is the underlying diagnosis of this deformity? The patient had an established non-union of a subtrochanteric femoral fracture. There were 3 broken quincher nails over a 9-year period. Why should this have happened? This is a poor area for healing due to damage to the nutrient artery. He was using 2 of the broken nails as fishing sinkers. He was unwilling to give these up unless success was assured with treatment. How should this be achieved? The treatment of choice is a Huckstep titanium locking nail with bone graft and elongation by 4 centimeters. It is essential to bone graft the defect, as in this case, from cancellous bone taken from the patient's iliac crest. Union occurred in 4 months. Question 172. What is the cause of this deformity? ulnar nerve palsy demonstrating an ulnar claw hand. What motor test can demonstrate other muscle involvement which will help confirm the diagnosis? Froment sign. The loss of thumb adduction by the ulnar nerve is compensated for by exaggerated interphalangeal flexion by flexor pollicis longus, which is innervated by the median nerve during strong pinch. The hand will also have weak interosseous function. Abduction and adduction of the fingers, plus extension of the fourth and fifth fingers at the interphalangeal joints. What sensory area may be affected? Sensory loss may include the medial third of the palm, half the fourth finger, and the whole fifth digit. Question 173. Discuss the injury sustained by this patient and why did it occur? A seatbelt injury. Note the diagonal bruising from the left shoulder to the right abdomen. This was due to a non-retractable seatbelt, which was too loose. List the many complications of this injury. Possible complications of this are a fractured clavicle, fractured ribs with penetration of the lung and a tension pneumothorax and hemothorax, damage to the pericardium with a hemopericardium and cardiac tamponade, and possible damage to the liver. The patient also had a head and cervical and thoracic spinal injuries. She could also have sustained injuries to other abdominal organs, including the ascending colon, pancreas, and small intestine. She may also have had injuries to the lumbar spine, pelvis, and the limbs. Question 174. What are these trousers called and what are they used for? Mast, military anti-shock trousers. These are pneumatic compression trousers used in a temporary emergency measure to splint fractures of the lower limbs and pelvis and to prevent pooling of blood in the lower limbs in the case of severe blood loss. 1 or 2 liters of blood can be prevented from pooling. The 3 compartments of the trousers must all be inflated by mouth or by a hand pump with a pressure limiter. These should only be deflated gradually once intravenous fluid and blood replacement has been given and the patient's condition has been stabilized. Care should be taken with transport by air or land over 1,000 meters, or when putting the patient in the hot sun. Under these conditions, the pressure in the trousers can increase, resulting in ischemia and gangrene of the feet if left for more than 6 hours. What other pneumatic splints can be used? An above knee splint as shown. Also above and below elbow pneumatic splints. Question 175. What name is given to this common fracture? The boxer's fracture, although it tends to be the barroom brawler. The true pugilist hits with his second and third metacarpals. A fracture may occur to the neck of one of these, as well as to either the trapezoid or capitate bones of the wrist. How should this patient be treated? Splintage is unnecessary apart from an aluminium cock-up splint for a few days. the patient is encouraged to mobilize early. With what residual deformity will the patient be left? A loss of prominence of the fifth knuckle is common, but does not compromise hand function. Osteoarthritis of the metacarpophalangeal joints is a common complication of boxing. Question 176. This man has had a below elbow amputation of his left arm. List the common indications for this. Indications include peripheral vascular disease due to atherosclerosis, severe trauma such as in motor vehicle and industrial accidents, primary tumors of bone or soft tissue, malformations either congenital or acquired, severe nerve damage such as in brachial plexus injuries. Discuss some important early and late complications. Early complications include infection and gas gangrene. The skin flaps may break down due to excessive tension on the wound. In severe peripheral vascular disease, the stump may become ischemic and re-amputation may be necessary. Will the patient ever feel that his hand is still present, and how is this minimized? Yes. Phantom limb pain is a pathological phenomenon giving the patient the feeling that the limb is still present. It is minimized by a coagulation diathermy of all nerves before division at the time of amputation.